Okay, today I want to talk about urethral strictures. So, what is a urethral stricture? First, we start with what is the urethra. The urethra is the tube that carries the urine from the bladder to the tip of the penis. Well, I'll just talk about the male urethra. Urethral strictures in women are extremely rare, so we'll not focus on that today. In men, the urethra is the tube that goes from the bladder to the tip of the penis. It carries the urine. And the stricture basically means narrowing or scar tissue that creates resistance to flow in the urethra. So, what are the main causes of urethral strictures? In the U.S., the most common is idiopathic, which is just fancy medical jargon to say we don't know. There's no clear history of any sort of trauma or anything. One day the patient just is found to have a urethral stricture. And we'll talk a little bit more about the symptoms and how they're worked up. But most of the time in the US, we don't know what caused it. It's just there. The second most common cause is iatrogenic, which again is fancy medical lingo for meaning we caused it or the medical community caused it with some type of treatment that we did, whether that was radiation for prostate cancer, some type of surgery or procedure, some type of catheter placement that went wrong, but it was caused by some other medical procedure or intervention. The third most common would be trauma, some type of pelvic fracture in a car accident or blunt trauma directly to the urethra or the penis. It's not very common, but it does happen. And the fourth most common would be infection. It's pretty rare in the US to see somebody with bad gonorrhea that just goes untreated. That can cause really bad stricture disease, but that's pretty rare. Um, so the symptoms are basically obstructive voiding symptoms, basically feeling like you have resistance to flow. It's hard to get the urine out. You strain to empty your bladder. In a severe case, it would be urinary retention, meaning that you can't urinate at all. Now, these are symptoms in older men that are often missed because of the much more common disease of BPH, or benign prostatic hyperplasia, which just means an enlarged prostate. So in men, as they get older, the prostate tends to cause somewhat of a blockage itself. And so when a man starts having those symptoms, we assume that it's because of the prostate. Now, there's some things that might make us suspicious that it's not the prostate and might require more testing. One, if it's a younger man, that's pretty rare. We don't start seeing issues with prostate growth causing weakened streams until at least 40 years old, but usually it's beyond that, 50s, 60s. So if a guy in his 20s shows up with these types of symptoms, that sort of raises a red flag. Another red flag would be these symptoms aren't improving with the typical pills that we give people to help open up their prostate. So even if a guy is in his 60s and these medicines aren't working, we might do some more testing. The common test that would be done in that situation is called a cystoscopy, which basically means a camera up the urethra into the bladder. It's done in the office with the patient wide awake. It's a little bit uncomfortable, but it's not too bad. But basically, you would look in with the camera, and before even getting to the prostate, typically you would see a narrowing, and a narrowing so much that the camera can't go through it. So then you've made your diagnosis of a urethral stricture, and then you get to the question of how to manage it. What do you do next? And before you can get to the management, you have to do a little bit more of a workup, because the cystoscopy gives you kind of a binary result. Is there a stricture there or not? If not, then it's done its job. If the stricture is there, you need more information about the stricture that you can't get from the cystoscopy. So I tell people it's kind of like driving through a tunnel and you see that there's a blockage. You know that there's a blockage, but you don't know how far back that blockage goes. You're kind of just looking through your windshield. So what you really need is kind of a bird's eye view to look at the whole urethra to see exactly how long the blockage is, how narrow it is, and exactly where on the urethra that blockage is. With the camera, you have some idea, am I closer to the tip of the penis or closer to the bladder, but you don't have that many landmarks to know exactly where you are in terms of the stricture. So to get that additional information that you need to decide how you're going to manage it, you need an x-ray, basically a bird's eye view of the urethra. Now, you can't just do a regular x-ray of the pelvis because you won't see the urethra. There's nothing that's radio opaque in the urethra. There's no calcium or anything like that. You won't see it. So to do a proper x-ray of the urethra, you need to first fill the urethra with contrast, basically a fluid that shows up on the x-ray. And so this is called a uretrogram, basically a Instagram picture of the urethra, uretrogram. And typically when you do this, we push the contrast with a small syringe up through the tip of the penis towards the bladder. And that's called a retrograde uretrogram. Retrograde because the contrast is moving in the opposite direction as the urine usually goes. So this is contrast going from the tip of the penis to the bladder. So a retrograde uretrogram, or a RUG, is the standard workup for a urethral stricture. This is somewhat uncomfortable, but it's not too bad. And so a lot of offices will do it in the office if they have the x-ray available in the office to take those x-rays and talk about what to do. In some offices, they might not have that capability, so you might have to go to a radiology center or even an operating room to take the x-rays. But then once you have the x-ray of the urethral stricture and you know everything you need to know about it, then we can discuss what are the management options. Doing nothing is probably not a good idea because it's not going to get better on its own, and you don't want your bladder to constantly have to push through this stricture. It can cause bladder problems in the future, urinary tract infections, stones, and so forth. So the standard treatment, what's most commonly done, is just a simple dilation. It's just what it sounds like. Go in there and stretch it open. And that typically works well if it's a short stricture, especially if it's not a stricture that's in the penis. If it's a stricture that's closer to the bladder, you can basically just go in there and stretch it open, and then usually we leave a catheter in for a few days afterwards, and then take the catheter out, and you hope that it stays open. And over 50% of the time, it will stay open for life if it's the right stricture, right? It's not too long, and it's not in the penis. Obviously, it can't be completely blocked off, otherwise you don't have anything to stretch. You can't even put a balloon in there to stretch it. But typically, it's not completely blocked off, it's just narrow. So they're typically just stretched open. The problem is, what do you do if someone has had it stretched open and then it narrowed back down again? In that case, going in and stretching it open again is most likely futile. Most likely you're just kicking the can down the road, and it's going to need to be stretched open a third time. And maybe for a very elderly patient who wants to avoid any other interventions, that's just what they do. They have it stretched open every so often. For some people, it's once a year or so, and that's acceptable to them. Also, if you have a stricture that you know is not going to respond to this dilation, say it's in the penile urethra or it's very long, then you should probably skip that step, because again, that's going to be futile. It's not going to be a long-lasting result. So classically, if dilation is no longer going to be a good option, then the next step is a urethroplasty, which is actual surgical reconstruction of the urethra. The details of exactly how the urethral reconstruction is done, again, depends on the location, the length, and the size of the stricture. Oftentimes we have to take tissue from the inside of the cheek to use as a patch to make the urethra wider in that spot. Sometimes we just cut out the strictured area and then we stitch the healthy urethra together, assuming that the strictured area is really short, and so there's enough healthy urethra that you can just bridge the gap. But that's sort of a whole discussion for another day. The idea is that this is a real surgery where we're actually cutting the skin and fixing the tube, and that works well. Afterwards, you have to have a catheter in for a few weeks at least. You have to heal from the incision. But success rates are over 80%, depending on the situation, sometimes over 90% for life. So you do it once and you're good for life. The downside of doing that is obviously you have to go through a real surgery, and you have to find a urologist who knows how to do urethroplasty or urethral reconstruction. And most urologists don't do that. And especially if you're living somewhere rural, there may not be anybody within hundreds of miles of you that does that. So access to urethral reconstruction is limited, and some patients who do have access just don't want to go through a major procedure like that. So within the last few years, sort of the new player on the market, the new kid on the block in terms of management options has been the Optilume balloon. That's Optilume. So this is a new dilation device. So this balloon stretches the urethra open just like a regular balloon would, but the balloon itself is coated with a drug. The drug is called paclitaxel. So paclitaxel is actually a chemo drug. This is not like you're getting chemo that's going to cause your hair to fall out and get really sick, because it doesn't really get absorbed into the bloodstream. The idea is that it just works locally. So when we do this procedure, we dilate the urethra with the balloon at the area of the stricture. We leave the balloon in for 5 minutes. This is with the patient under anesthesia. And the idea is that during those 5 minutes, the paclitaxel particles diffuse out of the balloon and into the area of the urethra and help to prevent the fibrosis or the scarring to come back, to help it not narrow as quickly or as likely, hopefully never at all. After that, we leave a catheter in for a few days, just like a regular dilation, take the catheter out, and we hope that it stays open. And there was a randomized clinical trial that was published in the Journal of Urology. They published several versions of the trial as they had longer and longer follow-up. But basically, they compared this Optilume balloon to regular dilation, and they found that patients who had the Optilume balloon were more likely to be stricture-free at the end of the study. So the thought is that this is better than a regular dilation. This has a chance of working in patients who've failed a prior dilation. Classically, the teaching was if you've failed a dilation in the past, then repeat dilation is just kicking the can down the road. But now with the Optilume balloon, the idea is that this could be an option for people who've failed prior dilation to help prevent them from needing a urethroplasty. There's some limitations to the Optilume balloon. It's not going to work for a stricture that's extremely long. In the trial, most of the strictures were under 3 centimeters. So if you have a stricture that's over 4 centimeters, the balloon is most likely not going to work. The trial showed that it had some efficacy in the penile urethra, but that's still up for debate. And the trial is not 100%, so you could get an Optilume balloon dilation and the stricture could still come back. And then in that case, doing another Optilume balloon dilation is probably just kicking the can down the road, which again, for some people, especially if the Optilume spreads out that interval to 2 or 3 years, they'd rather do that, have this minor procedure with no incisions than have a real reconstruction, especially if it's an older, sicker patient. But for most patients with just a younger patient, that they just want to have it fixed and not have to go through multiple procedures. They just want to have the urethroplasty at that point. Some people will choose to go straight to the Optilume instead of doing a regular dilation first, which is sort of off-label. That hasn't really been studied in the trials. They sort of only chose the high-risk strictures to study. But that is something that at least logically makes sense, to not even try to use the old-fashioned balloon, just go straight to the Optilume the first time. I think it's reasonable, even though we don't have a lot of data to support it. And then if that doesn't work, then moving on to urethroplasty. But this is a bit of a difficult condition with a lot of different options. It really depends on the patient and the stricture. And so if you are found to have a urethral stricture, you probably want to be seen by a reconstructive urologist who specializes in this. Most urologists don't. So it's definitely something to look into and think carefully about if you get found to have a urethral stricture.